Michael, how do you approach these patients for molecular testing and monitoring?
Sure. I think, the more information you have, the better. So, certainly PCR is our workhorse. So having baseline transgroup levels so we can measure early response, which really gave us direction in this case, was vital. So baseline BCR-ABL testing before treatment exposure, I think, is very important, and we have that in this patient. In addition, historical and classical testing of CML is also important. So not just molecular testing, but cytogenetic testing, classic cytogenetics. And of course, the bone marrow is still indicated, in guidelines for a newly diagnosed CML patient to rule out accelerated phase, to look for any other features. I'll bet my colleagues kind of agree, and we try to get as much as we can, before we start treatment, so we know where we're going.
Often we get patients referred without bone marrows anymore. They get PCR done in a city or FISH testing, karyotyping, and they said that's chronic phase CML. As you clearly highlighted, a bone marrow is a must for these patients to be done up front. I'm not saying biopsies, but at least to have a bone marrow aspirate and evaluation of the bone marrow findings before going into therapy, and then knowing what kind of transcript we have, because sometimes we can have the atypical ones that we miss to diagnose up front, and we get somebody on therapy coming to see us. We call them, quote unquote, they are in CMR, we're excited to stop therapy, and we missed the right transcript, and we have no way to follow them.
Great points. I think it's tough because the risk stratification for CML, you can stratify a patient without a bone marrow. But on the other hand, if someone is being careful and looks at guidelines and understands all the breadths of things you want to understand at diagnosis, a bone marrow is essential.
I think there's another interesting clue here that the blood count's a little atypical for a traditional chronic phase patient, right? So they're a little bit anemic, they're a little bit of thrombocytopenia, that you may not typically see that in patients. So you want to understand what the bone marrow, what's happening in the bone marrow. 8% blasts in the peripheral blood raises a flag to sort of suggest that maybe this is more advanced phase disease. So again, I agree with everybody. A bone marrow is clearly indicated when you're newly diagnosing and staging somebody with chronic phase CML.
And Adam, do you feel like a bone marrow is usually useful at the start of treatment?
Yes, I do. From a hematopathologic point of view, the primary reason for getting a bone marrow is to get good quality metaphases in which the yield is likely to be better than in the peripheral blood. Not that you cannot get metaphases from peripheral blood if there's sufficient numbers of dividing cells. And of course, sometimes on occasion, the phase of the disease that may seem chronic in the peripheral blood may be more advanced in the bone marrow. But I think it's also important just to sort of overview the initial discussion point of what molecular testing should be done. We should be cautious about, as has been highlighted, not restricting ourselves to molecular. It's genetic testing broadly spoken. And so there's cytogenetics, there is molecular genetics, and molecular genetics, typically RT-PCR-based analyses, and FISH. We haven't really spoken about FISH. I'm not going to talk about FISH immediately, but just to highlight the fact that classical cytogenetics is still key for the initial diagnosis of CML and to determine whether there are or are not additional chromosomal abnormalities. Their relevance we can discuss later on. With regard to RT-PCR, important to realize there are two types of RT-PCR that can be performed, qualitative and quantitative, giving us different information. Qualitative PCR is still required to determine where the breakpoint is. Yes, you typically expect an E13 or E14 breakpoint, but on occasion, 2% of cases perhaps, you will find them in other regions, and that may not be picked up on subsequent quantitative RT-PCR, which is used for monitoring. Should we be using quantitative PCR at diagnosis? I think that's still an open question of whether that's useful, and I think emerging data suggests it may be, although historically we have not done so or mandated that, comparing patients' kinetics to the international standard. But maybe it's better to just compare kinetics compared to the patient's quantitative level at diagnosis. With regard to FISH, I think FISH can certainly help in the initial diagnosis of CML. It's as good as RT-PCR, although perhaps even better than RT-PCR, since FISH probes span a wider region than PCR primers, and you will, with FISH, pick up positivity when RT-PCR may miss the breakpoint.
Let me ask you a question. At
Sure.
my institution, we do FISH and PCR and cytogenetics
Yeah.
by GBA technique. Do we need FISH if you have a good karyotyping and you have a molecular? Because that's an added test.
I don't believe we do. I'm not sure what the added value of doing FISH if you've got positivity by
Correct.
RT-PCR
So if you have
and you've got
RT-PCR
cytogenetics.
positive, you
Yes.
have the breakpoint you
Yes.
want, and you have a good 20 metaphase analyzed, and you have 922 plus something else you want, you do not need FISH.
I agree with that.
But then you can use FISH for the follow-up. Eventually, you can
Perhaps, yes.
I think you made a great point on the identifying the fusion type, because I think there's definitely emerging data that there may be differences between patients within the typical fusions, E13, E14 response, perhaps treatment-free remission. And that's at the clinical level for providers, that's an important question, because the test they order may not tell them that, because if it's a broad molecular assay, it's not going to tell you whether it's which breakpoint it is. It's just going to quantify it. And I think I'm finding myself ordering both. A separate study it's qualitative, but it's going to tell me which fusion type, and a quantitative, which is going to give me the patient's individual baseline. So I can probably use both, the international standard expectations, and then put that in context. If the patient was well above 100%, and they have a good 1 log reduction in early molecular response, that's probably sufficient. They may not reach 10%. That you have these judgment calls.
But Mike, this should not be a part of standard of workup when you get somebody, because when they come to see us, we will do all this automatically upfront. It's in an EPIC system where we get all the atypical, the full things, quantitative and qualitative. It's not done at your institution the same way.
No, you have to. I think a lot of providers probably face that. They're looking at molecular assays and making choices.
Okay.
So I think that it's important that everyone knows what are they looking for. And I think that knowing the level, probably knowing it's a typical fusion and perhaps which type, may not change your approach to the patient, but at least having that data so you can start. And as you navigate with the patient, you're going to be able to make good decisions.
And, and we're paying attention as well to cytogenetics, especially certain abnormalities, and we'll discuss them hopefully later during our tumor board. For example, isochromosome 17, which we know they don't do well, these patients, and they may have to go to second, third line immediately and go for transplant. So it's still required to do karyotyping and that